Familiar, new, new. Okay, I'm seeing some here. Thank you guys. Okay. All right. So the folks that have answered here, it looks like some familiar, but the good majority. Let's see, I'm getting some more. Okay. So let's say maybe a 50-50 deal, Ashley, is what you're seeing through the chat on there between new and
Yeah.
familiar. So we'll go through this piece of the puzzle and then that helps set the framework for how we do it. So here is the new nurse leader core competencies model. It was updated to reflect the new current practice of nurse leaders. So we're going to get into each of the little circular pieces, understanding the leadership in the center, and then that leader within that kind of frames this piece of information. And as you can see by the model, they're concentric circles that overlap. And as we break out each piece of that, you'll see how they overlap together, but there are some distinct pieces within each core competency that develops based on the area. So it is a framework for knowledge, skills, and abilities associated with effective leadership and really uses the continuum of experience. It's representative of the breadth and depth of nursing leadership specialty across settings and roles. And some of this change as we progressed in AONL is really understanding that nursing leadership happens in all settings of the continuum of care, not just in the acute care spaces, but in long-term care, in our ambulatory settings and other areas where nurse leaders practice. So that's some of that expansion and revision work that you've seen through here. It's built on work that began in 2004 as part of AONL's participation in the Healthcare Leadership Alliance, to give you a little historical background. And it uses with anchors with 5 core domains. So business skills, communication, relationship building, knowledge of the healthcare environment, professionalism, and then leadership. Based on the A1L leader competencies, these represent the functional competencies for nurse managers. So, and are building some of that foundational pieces. And you'll see as we build those, how that kind of comes together. They reflect the knowledge, skill, ability, and personal characteristics required to produce activities that generate observable and measurable results. Because as we know, nurse leaders were held to come out with outcomes and have measures, right, in order to show success. And so we kind of lean into that as we begin. So the core leader competencies are the foundation for all leadership skills. They are applicable in all settings. It kind of reminds me, if you are thinking about your nursing teams, you come out as a registered nurse, you are essentially that generalist, and so you should be able to function in a space, right? So thinking on the same lines here is that core leader competencies, getting some general leadership, everyone should function and it can be applicable. Then we add on functional pieces of that next triangle. So this is manager specific roles. They're specific to situations and circumstances, but can be applicable in all settings. But that may be that caveat or that additional layer of information that you need to function as leader in your space. So maybe the leadership skills and characteristics look the same, but the relationships, as an example, that you may have with your providers may look different if you work in perioperative services than it does if you work in an acute care environment where you're working on an inpatient nursing team. Surgeons, anesthesia team that you work with, that camaraderie, that connection, it's a multidisciplinary group, may look slightly different than the one you may have in your inpatient setting, which would also include like admitting physicians and consultants, but maybe not that elbow to elbow daily interaction that you may have in perioperative spaces, or it may look the same. Critical care may be looking different, long-term care, and et cetera, but using some of that same information. And at the very top are the results. So these are the outcomes that are required in order to say that you are effective in your leadership. It's an expression of those competencies and really as the application of all of those additional layers that showcases at the top. Make sense so far? Any specific questions to understand a little bit how that's layered and how we go about that here at AONL? Okay. So we're going to dive into the core areas that we mentioned earlier. So professionalism's area we're going to be covering today. That includes professional accountability, organizational accountability, health equity, and social determinants of health. You know, a hot topic of how we are individualizing care and looking through that next layer lens. And governance. So not only governance locally, a little bit about professional governance, but also talking about governance at the board level. So those folks who are at the highest level of a hospital and how that interaction comes from nursing. Communication and relationship management will cover areas like relationship management, effective communication, and influence behaviors. I think this is the area that we spend the most time in as a nurse leader across any settings, and where you do most of your work. So this area, I imagine, is going to be very comfortable for you, should draw from all sorts of experiences, but it helps to know a little bit more about how to engage that or some tips and tricks. So that's what I expect from that area for you. Knowledge of the healthcare environment. So we're talking about nursing practice and application, patient safety and quality, economics and policy. We know that really drives a lot of the things that happen in our healthcare environment today. Regulation, and then evidence-based practice. What are we looking for next? How do we look for the what evidence is to support that? What other regulations and things do we need to think about for expansions? Business skills and principles. This is where our financial knowledge comes in, strategic management, and then human resources management. And I think that's another area that we spend a lot of time in, is how do we lead people? How do we manage people? So there's those things related to that work that we will cover in there. Leading up to finally on leadership. So looking at systems and complex adaptive thinking, diversity, belonging, and inclusion, decision-making, change management, and then transformation and innovation. So really circling in on how do I bring those pieces together, looking forward thinking, and leading at the best, highest level that you possibly can. Any questions about the content outline and what we're going to be covering over this course? Okay. So scenarios. So wanted to make sure I kind of delve a little bit into what those look like. So these are examples of situations you may face often in your work. They're designed to be discussed in either a small group format or in the entire class setting. And that's when we'll use the chat feature, have you come off mute, as I alluded to earlier. These weave together threads of functional competencies and the material so you can see how it is applied in real world practice. It does give the opportunity to reflect on your own experiences and perspectives, but really to learn from your colleagues within this group. We've got a group of 50 some nurse leaders from across the nation with different experiences that we can all learn from using this framework to kind of shape our learning. And that's really what they're designed for. So we hope you're going to have really great engagement with those. Help us make them engaged by providing feedback to us, and your experiences really help everyone in this learning platform. So we look forward to doing that with you today. All right, I'm going to jump right into professionalism. So this is going to be our first topic for today. And we're going to start off with a practice question. And so I'm going to read the practice question. You'll have 4 multiple choice questions. It'll look very similar to what you'll face on the exam. Tony will pop up a poll and allow you to answer that question using the poll so we get it to be more interactive. So here's our first question. Which of the following barriers may inhibit the use of research in clinical practice? So you have 4 choices there. I'm going to give everyone just a few minutes time to answer that question as soon as Tony launches that poll.
Yep, just give me 1 second.
Not a problem.
Check. Technical difficulties with launching. But I see people are answering in the chat. I'm sorry.
Okay. All right. Well, I appreciate them. being very flexible. Look at us go.
Yeah.
Got it.
All right, I'll still launch it, but yeah.
All right, you could be ready for the next one, Tony. That's fine.
Okay.
There you go. Oh, I got folks popping in there. Thank you guys for being flexible. You're amazing.
All right, so it seems like the chat and the poll is
Yep.
aligned to be, yeah, I'll end it.
Perfect. So I got the idea here that most of us have picked B for that. There we go. Excellent. So majority of us have got this right here. So here we're going to talk a little bit about the answer and then a little bit of the rationale to help for those folks who may have answered a different question or weren't sure one answer versus the other. So we'll go through that piece of the puzzle here. So when we talked about barriers to inhibit the use of research in clinical practice, formalized nursing education levels have minimal impact on the use of the research because nurses at all levels can potentially use that. So let's talk about organizational size. It may not have the impact on the use of it. However, geographic location sometimes, and if you're talking about some rural and critical access households may affect access to that critical information. So once they have it, they can still use it. We know that ANCC magnet designation really supports the use of research. So it doesn't have any impact on that use piece of it, but it increases it, but in this case doesn't answer the question. So inaccessibility of relevant literature really is the ability for us to get that research and have the key element in incorporating into practice. So great job. We're hot and running today, guys. You're doing great. Question number 2. A nurse manager is experiencing problems with an RN delegating tasks to an unlicensed personnel that are not within the scope of practice. The nurse manager plans to review the principles of delegation with the RN. Based on this information, an additional action the nurse manager should take time is to examine which of the following legal documents. All right, Tony, whenever you're ready. Did you already? Oh, there it is.
Yeah, I
Sorry,
launched
it was on my other screen. I was like, I didn't see nothing.
It's at 56%, so I'll just give it a little more
No,
time.
you're doing great. Thank you.
70. See if we can get up to 80. Couple more people.
Almost there, guys.
So close. All right, awesome. Oh, got a couple more coming in. Okay. Let me share the results. Can you see the results?
Yep.
Shared? Okay.
Yep. So I see that the majority have picked B, but we do have a chunk of us who picked A. So let's take a look at that. All right. So the answer is B, which is the State Nurse Practice Act. So let's roll back a little bit to understand what the difference is between A and B. What are the two answers here? So we're looking at legal documents that are really going to help us understand the delegation of the RN. So ANA scope and standards of practice, which really provides us authoritative statements on nursing profession. It's not a legal document. And that's the thing I think that makes it distinctly different from some of the other things. So it provides us a framework to work from as a nursing profession, but not a legal document that provides standards. The State Nurse Practice Act is specifically a legal document that guides acceptable nursing practice in a given state. And so that really talks about delegation of tasks. I think another thing that comes up is about maybe not the scope and standards is next, but code of ethics, as we have talks about outlining nursing behaviors, falling in the same lines as the scope and standards. And then the social policy statement really expresses the contract between society and the profession of nursing. Again, just not a legal document. Were the questions helpful? I got some. Thank you, Stephanie. I can see your face, so I appreciate that. All right, perfect. I just want to get some framework right. All right, so let's dive into a little bit more about what you need to know about professionalism. So when we talk about professional accountability, this is that umbrella that really looks at the ethical principles you used in decision making. It talks about standards of nursing and leadership professional practice, competency and certification. You may really lean into the scope and standards of practice here as something that kind of helps you a little bit understand this area. And then roles of that professional organizations for yourself and your staff. So how do you connect your teams to the ideas of what standards of practice look like? Like what's the expectation for a nurse? How does that work within your unit? So we're talking about like assessment standards. Maybe it's something along the lines from leading people with things like professionalism. It's customer service oriented pieces, understanding quality, that quality piece and how that goes into some of that professional practice pieces. And then leaning into your professional organizations as the source of what's driving evidence-based practice, research in those areas. You look to those for your expertise within that clinical space to help lead that piece of the puzzle, if that makes sense. So really, how do we lean into that professional accountability? Where do we get that information from? And then how do you express that really clearly to your teams as you're leading what your expectations are for nursing, what accountability they have daily, and managing that at the local level. When you think about organizational accountability, so moving up that next layer, so this is an alignment of your personal values with organizational culture. If you've ever had experiences where you've worked in an organization where what's been asked of you or what has been expected doesn't really align with your personal values, you know that there's a rub there or some potential moral distress here when that doesn't work. So we do want to make sure that in this case that's the case, that is the cadence and the course for you, is that how do those align with the quality and safety metrics that you're driven for, the community support, those kind of things from an organizational level. And then elevating the voice of the patient. So how do we incorporate patients or patients' families in that decision making? Sometimes that comes through things like the patient family advisory councils, if you have some of those available to you, and incorporating that decision in practice changes or facility changes or upgrades in patient education. I've seen that done in those spaces. It's a great way to ensure that the patient's voice is heard, and what we intend to improve is really what you actually get in the long run. And so I think it's superbly valuable to have the voice of the patient when you're making changes like signage and wayfinding to I'm updating my education book on stroke for patients and incorporating that to be sure that the language makes sense and what the deliverable looks like helps enhance the understanding of patients and families and that nurse communication. We talk about a culture of accountability. So how do you as a nurse leader establish that, and how is that shared or expected from you, even from your CNO level? So I think about the famous statement is what you permit, you promote. So what does that look like at the unit level? How do you do that? And then how do you have folks that in informal leadership roles do the same? So this can be an assistant manager, this could be a charge nurse, this could be things like your nurse practice council chair, some of those informal leaders. What is that set of accountability? How does that peer-to-peer accountability been built? What is the culture of accountability across divisions, across interprofessions? Like some of that kind of goes into some of that play. That leads into I'm accountable for some of my outcomes. So how do I achieve those outcomes? And then what have I put into place as a leader to ensure I'm meeting those metrics? So whether those are those accountability measures, standards of work, and measurement, and then looking at that data and then putting things together like process improvement, action plans. We'll hear more about some of the work and some subsequent things, but really trying to understand how you drive your outcomes, because that's really what produces the work that we're looking at. Supporting career development for your staff, I think, is another key piece here for our organizational accountability. The nursing literature shows us here that nurses come in expecting to be potentially in our spaces for just a short amount of time compared to about 5 to 10 years ago, where, they're here for 1 to 2 years and they're really looking for that next level, that next nursing step. So how are we ensuring that we have an open mind to that idea of that nurses are no longer going to stay in our spaces for as long as we are, but at the time that we're there, we're arming them with the best information possible to care for our patients, but also opening the doors and avenues for them to continue their growth and career paths. In the long run, promoting them to places like your charge nurses or preceptors, looking to see how you advance them in clinical ladders, which we'll talk about later, and enhancing that growth. Is this the next nurse manager? We'll talk about that in succession planning. So giving you some ideas of how that may look. And then leadership presence. So how do you show up as a leader every day? What kind of picture or expectations are you painting through nonverbal communication, through written communication, through daily interactions with your team? What does that look like when you are you rounding with your teams regularly? How do you put that into play? How do you engage with your practice councils? That'll come up a little bit more in professional governance, but thinking about all the aspects of what leadership presence means and knowing very clearly that your teams are watching you every day. And so, and then giving you the opportunity when things are vulnerable for you or there's been a misstep, circling back with the team to show that in itself you recognize that and that you can circle back and correct that or change that purview or that view of what that was. So some things to think about. You'll hear more about that in the communication area. When we think about health equity and social determinants of health, I think anywhere in the literature within AONL or any of the areas in the health equity issues are coming up all over. And some of our regulatory and federal agencies are really asking us and pushing us to really look beyond our standard work that we used to do from 5 years ago, but really want to understand in your community, in your populations, how are we really serving that community well? Can you speak to that? What work potentially are you doing for that? Closing the loop on some of those things is helpful. So that can happen in like your interdisciplinary rounds, communications with physicians, reaching out in your community. So that comes into that some community outreach pieces of the puzzle, working with some of your programmatic levels. So if you're in the neuroscience division, what does that look like for stroke area? If you're in our cardiac area, what does that look like for resuscitation measures or the goals and things in that area for heart disease and stuff like that, blood pressure management, those kind of things to keep in mind to be sure that our nursing teams are prepared and provide the care across the continuum equally for everyone. And that when new ideas or new things come up, that they're ready and prepared to take care of a patient that may have some individual needs that they may not see every day, but may be a part of your community. Some things I can think of is in maternal spaces, in maternal services spaces, when you think of women coming in with cultural backgrounds where they can't have male providers, and when there's limited folks who can come in and out of their patient rooms, where only portions that their face have to have their face coverings on if they're going into the OR spaces, and how do you work with that when the mom's getting a C-section? Those kind of are just some examples of how we wrap around some of that to ensure that the nursing teams and our clinical teams are ready to care for patients like that. Does anyone have any experience working in these kind of spaces and has something they can share here with culturally appropriate care or health equity? Anyone out there?
It's
Liliana.
Like I think we all hit kind of a little bit of this in each of our days. My prior institution was UCLA, and we would get, quite a few Spanish speakers, and
Yep.
not all of us were Spanish speaking. And we actually had a gentleman who everybody who was Spanish speaking and all of us non-Spanish speakers kind of assumed he spoke Spanish. And because he was from Mexico. And so he actually spoke a specific dialect. So he didn't understand anything that was being said, even though he was doing the nodding, like, yeah, yeah, yeah. So we ended up identifying his specific dialect, finding an interpreter that we could assign specifically to him, getting ethics involved to make sure he understood his, oncology and cancer treatment and everything. So.
Right. A great example. And sometimes you have to lean really hard into some resources that aren't around, or think differently of how to access that, especially if it's a unique or something that's not found a lot in your community. Liliana, I think you were going to share something as well.
Yeah, I work in cat lab, and many times when we have a STEMI, the whole family comes with the patient, and they want to be there. So it's very important to keep them always updated with what's happening. Usually I stay or I have a nurse staying with them. We have a chaplain at all times staying with these patients. And if we do not speak their language, because it happens lately a lot, we have that little robot, the green one, the interpreter that comes with us, and we use that. It's really important to keep these visitors within a STEMI, a heart attack case, calm, and because it can go wrong in a second.
Yeah.
If they are not kept aware with everything that happens.
It's true. Absolutely. Ashley, you have something else to share with us?
Hi, can you hear me?
Yes, ma'am.
All right. I think when I was bedside, I think the biggest thing that I saw was the need for education on end of life care.
Yes.
We would have a lot of patients on the units that I worked on, and the biggest knowledge gap was the end of life care. Some of us would say like, oh, we can't let them suffer. But in some cultures, suffering is like going through that suffering is like, I believe, like showing a worthiness to be allowed into heaven, So I would try and educate on those types of things, but I think that's a really big gap. And that needs to be better understood so that people are dying with that dignity.
Yeah. And I think that brings up another piece of the puzzle, Ashley, is that some moral distress related to how families or even patients' decisions sometimes don't allow with their own personal values as a nurse, right? As in a person. And how do we rectify that using the resources internally with our team, whether it's like ethical consults or just getting the team together with our spiritual health team or whoever is an expert in your area for that to talk to the teams through that, because I can see that being part of the puzzle. And then I would agree with you. End of life care, I think, is something we could definitely spend more time in helping our teams be prepared for and what that looks like, between things like hospice and what that care looks like for, and then the end of life and how we work through that. So I agree there's opportunity for us to improve those pieces. Jennifer.
Hi, good morning. Yes, that's very true. I'm not particularly sure. So we recently had this, it's a religious limitations as far as blood resuscitation. So we had a very young patient that recently had an aneurysm in the OR, and then we had to transport back to ICU. But we need to give blood products other than what is actually needed. So the staff was very, very having that moral distress. So, yeah, and then that we're not everyone is ready for that end of life,
Yeah.
especially at a young age. So,
Correct.
yeah, these are some of, and then the family was very firm on that from the very beginning, since, prior admitting to the intensive care unit. Yeah, those are, it's still, like while you're in nursing school, we've talked
Yep.
about these things, but when it come across, it just truly affect the morale in the unit.
Absolutely. Yeah, absolutely. Something to think of. Jennifer Bacal?
Yes,
There you go.
me. Yes, thank you.
I apologize. I didn't say that right.
Yes, thank you. Um, First of all, I being a house, I in the hospital, it's I encounter a lot of cultural, trying to, how do you say it? I have to be very careful in respecting the culture of every patient, including the family. And it affects also how their care experience, goes along from day one. And one of them also, besides palliative care and providing comfort care and end of life, yeah, there is indeed a conflict in related to religion. So I did tell my charge nurses that, when it comes to Buddhism, based on my experience, I have to be very careful of advising family when I visit, when I round, that, it's okay to let go, but they may not able to accept it because it's a conflict with
Conflicts.
Buddhism.
Yeah,
Yeah.
absolutely.
Yeah, it affects the reincarnation,
Yeah.
so I have
Important.
to be very sensitive on those.
Correct.
At the same time, I did have handled patients who are geriatrics. They come to us and they're very sickly, and it affects also what kind of family, the sex of the family who can come and stay with them. So I experienced that a lot with people who practice Islam. And if it's a woman, it has to be a caregiver by a family, which is a female.
Yeah,
So we have to be very flexible as
correct.
much as
That's the key.
possible.
Right.
Yeah,
That is the
yeah,
key. And provide the resources the team needs. And that you're going to have to assess as the leader of that area about where those community resources may need to come in. You may need to think differently about how to get that done 100%.
yeah. So,
Yeah.
but that's correct. Yes.
Thank you.
Thank you.
All right, so on role of professionalism, we talked about governance. So I alluded to a little bit earlier about the role of the governing body. So in an organization, understanding your connection to that governing body of your organization and how they set the tone for your KPIs, your focus of where your team is going to be focusing on for the year, and being able to communicate that effectively to your team, and also advocating with the board. So if you've ever had the opportunity to showcase your team and your outcomes to the board, that's a great experience. But then how do you advocate if as far as like resources for the team and or outcomes for the team, or where you want some of those key metrics to land in on through your CNO and other leadership levels, but understanding that there's a connection between what the governing board is giving you, how you articulate that to your team, and then how that drives the organization as a whole to the next level or the next direction. So I'm giving you a little bit of pieces of that. May not have had that experience, but one way to look at it. So the wrap up for here is about dimensions of advocacy. And as you can see here, there are 3 levels overall that we kind of talk to here. So patients, staff, organization, and community. And the nurse leader has a role in each one of those. And it may look slightly different, but understanding your role as an advocate is super important as a nurse leader. And depending on who you're talking to, how that can be at your local level where you're advocating with providers or clinicians there. It could be advocating with your director or senior nurse leader, your CNO. And it could also be advocacy if you talk about organization community, either with AONL, like Advocacy Day, when you're talking about like with federal government and understanding how the senators and those kind of things advocate and understand your work and the impact that nursing provides to patients. So it kind of includes all of those dimensions. So take a look at that piece of the information. It may be something you do daily, but it may be some things that you're interested in pursuing further, like the organization and community level, like participating in some of our advocacy days that AONL does, trying to understand and reach to our how policies are shaped and how to get in front of elected officials. And some of that work may be new to you, but it is part of that dimension of advocacy that we were referring to today. All right, so now we're going to wrap up with just a scenario here. And this kind of looks at a way to kind of leverage all of what we learned here. So I'm going to go ahead and put that on there, and we're going to talk to this as a group. So you've identified several nursing care related concerns in your department and are not achieving your quality metrics. You'd like to engage your unit's professional clinical nurses in finding solutions for these issues and believe a unit practice council would be the best mechanism. There are no existing professional shared government structures in your organization. So it's never been there before. So I want you to think about these 4 things. We're going to give you just a few minutes to think about them, and then we'll answer those with some volunteers. So what are your first 3 steps to begin solving this problem? What consideration should be given in the development of structures and processes for your council? How will you get nurses engaged in and supportive of the council if they've never been in one before? And then how do you elevate professional practice through this effort? So I'm going to give you guys about 5 minutes to think through those really quickly if you want to jot down some ideas. And then we'll either call out some folks or some brave volunteers would be kind enough to come off mute and talk through that. And we'll talk as a group. How's everyone doing? Are we ready? Or are you gonna need a few more minutes? Give me a thumbs up if you're ready. Thumbs up if you're ready. There we go. Thank you, Ashley. Perfect. Now we're getting them. Okay. Thank you, Julie. Perfect. Ashley, are we getting some good responses? I can't see, but just a few people.
There's some questions in the chat, not necessarily related to this though, that we'll have to answer.
Okay, thank you. All right. So what are your first 3 steps? You're trying to solve this problem. What do you think? Who wants to give me an answer to start us off with?
Hi, this is Christy from Wisconsin.
Hi, Christy. Thank you so much.
You're welcome. So, I mean, there could be multiple steps, right? But
Yeah.
a few that came to my mind was seek to understand what the vision and strategic plan for governance is, whether it's with your CNO or CNE, so that you can be aligned. And then I think if it's new to the team, that we need to share and communicate and educate what a professional counsel does. What does that mean to their work?
Right.
What they can do to influence that and what that means. And then I think that as far as what consideration, oh, are we just sticking to one?
That's all right. Go ahead. You can go on to the next one. Go, girl. You're on fire.
As far as considerations or criteria, I really think there needs to be set standards as far as the expectation of the team members, what the amount of time that it's going to take, and they need to commit to that time, and put effort into showing up, doing minutes, communication, all the things that's really got to be, it's got to be followed. It has a structure for a reason.
Yeah.
And then number 3, how will we get the nurses engaged and supportive of the council? They have to be individuals who are motivated to drive change, and not everybody's great at that. So
Correct.
these are special individuals that are motivated. They really want to improve processes that affect the frontline nurses, their colleagues. And so they're those individuals that you kind of see as your shining stars, the ones that are getting involved anyway, and just really putting time and energy into those individuals, because they're the ones that are going to, like I said, drive change. And then how do you elevate professional practice through this effort? I think I already have a unit-based counsel, and what we do is it's not just given to you. I mean, you have to apply. You have to have so many years of service under your belt before you can get into the council. You have had to had certain wins throughout your career as well. And so making it, sought after as a very authoritative, maybe that's not the right word, but that's a cool place to be. You want to be part of that team because there's a lot of good things that are going to come out of this council. And so by leading by example, others want to be a part of that team.
I think this is where one thing I would add to that is that this is where decisions are made about your practice. So if you want to be part of that solution, then this is a great place to be. But you've hit some really important parts, Christy.
Thank you. I just think if we're not part of the change is going to be done to us.
Exactly. That's a very important part. Carrie, you've had your hand up as well. What else would you like to share?
I agree a lot with her. The gathering of information for number 1, you have to get administration of what they're willing to allow a committee to do.
Right.
Getting that input too from all team members that want to, letting them know that when they come together and that their voice, it has a meaning, and gathering those together and putting that data together. Once you have that information to be able to present to administration is huge. For number 2, you have to identify who those people are on your team who are willing to give more. Just as Christy had said, you have to know who's going to give more, and you also need to identify your naysayers per se, of who can go against you, so you can identify them right out the gate. And then for 3, allow them to see that constructively gathering that data and the presentation of the information to administration once you do have your team developed, and see the little goals, little steps add to make bigger steps.
Absolutely. Very good. I see your hand, Stephanie. Stephanie C. There you go.
Yeah. Oh, thank you. Yeah. Oh my God, you guys had such great points. You're so inspiring. I think Christy is probably a fantastic leader based on what you had to say. But I will say I actually just had my team start a UPC on the unit. And I think one of the biggest areas that we could have done a little bit better is maybe do some lit review prior to starting. So I think definitely getting the exec buy-in and all of that. We didn't have to start everything. We had practice, governance, structure, and bylaws and things like that. Just my specific unit was new as of 2024. So it's all new staff, all new everything. And I think that you guys bring up really great points. And one of the things that we're really honing in on is that you have to be a part of creating the change. Otherwise, it will be thrust upon you. I thought that was a fantastic line.
Excellent. Lots of great conversations and support in the chat too. So thank you for those folks who are putting in some insights there. I think we really hit, I'll go through the little answers here, but I think we've hit all of those things here. So first 3 steps, Stephanie, one of the things I suggested was a literature review, and this is based on the fact that no one has had any experience on what professional governance looks like, and you need a base to start with. But if you've had that base, then it's really reaching out to those folks who already have a structure or understanding. And then you're right, you need to make sure you get some buy-in from that, from your administration, your executive team as well. A champion who can inspire and others to participate, that's super important. Resources for yourself and your team through these ideas here. And then how that the nurse managers and the clinical nurses establish those things. So I think it's important. On structures, we talked about who will be members, what's the process to bring practice related issues in there, how are the issues activities prioritized, like how do you work through that? Decision making, we talked about level of authority with a couple of the folks there that is important, and scope of the council. What's not included? Staffing the unit. So you know what I mean? Those are things that they tend to want to talk about. So those are some pieces to think about. And then how information is shared. I think one of the ways that you can elevate that practice is mentioned is really showing those small wins. What does it look like when we have a successful practice council, giving them some examples of what that looks like and the outcomes that they've changed for patients. And that's really the guiding principles here. Getting the staff engaged and supportive. So communication and the intent. We talked about the why is it important? Setting boundaries, providing examples. There was a lot in the chat, which I really appreciate. I think it's Liliana, but I'll go back about listening. Let me go back a few here. Change agents. You guys have got some. Oh, investigate, listen, and communicate. That was Miss Fee. So I think those are important things to remember. Visible leadership support from yourself and others in the nursing practice, and then explaining how the formation advances practice we talked about for a culture of excellence, linking these things together to evidence and standards, and then including discussions of professionalism and professional accountability. And it's built within our structure, guys, as registered nurses, that we should be doing this work. So how do we continue to foster that, if that makes sense to everyone? So that concludes our first section. I hope this gives you some idea of what we're into for the next. And I'm going to turn it over to Ashley to get started on the healthcare environment.
Thank you very much. And I also want to call out Ashley Fuller. I loved your thought process too for your unit-based councils that are working on an annual project. That's really cool. Oh no, okay, can you see my slide or are you guys seeing yourselves?
Nope, you're good. You did a great job.
Okay, perfect. Perfect. We're going to start now with the knowledge of the healthcare environment. And I can't see you guys at all, so apologies. If you're raising your hand, Andrea, if you could do that kind of stuff for me.
Got it.
All right, so we're going to get started here with a practice question here as well, just like we did for the last section. So elements for establishing and maintaining a healthy practice environment include a collaborative practice culture, shared decision-making at all levels, and adequate numbers of nurses, clear accountability, Nurses Week celebrations, or policy-driven decisions. Can we do the poll for this as well, please?
Yes, so sorry. I am attempting to get the slides. My computer's being a little slow. Let me do this real quick. Relaunch.
And I'm sorry, Tony, because I told you we weren't going to use this during this today. So I apologize. All right, looks like we're getting some responses now. %, getting pretty close. All right, 80. We hit that 80. Okay, so looks like we have a little bit of a mix here. So the majority says B, clear accountability. There's also a couple A's, adequate number of nurses, and some D's, policy-driven decisions. So let's go through these. And here, did I skip that question? Nope.
Do you want me to pull it up for you, Ashley?
Yep, because I think I put I must not have the facilitator one up.
Yep, hang on just a second. Let me get that for you. Hang on 2 seconds.
I actually have mine. You guys just won't see it on your screen. So let me go back to that question. Okay, so
You got it?
a lot of people picked A, which was adequate numbers of quality nurses, is one element of the healthy practice environment. The number of nurses alone, though, does not necessarily result in the healthy environment. B, which is what the majority of everyone picked, is the correct answer, clear accountability. Clear accountability is one of the nursing organization's alliance principles and elements of a healthy practice environment. So that is why that is the correct answer. Nobody, unfortunately, as much as we all love Nurses Week celebrations, picked C. Nobody picked that one. But D, a couple people did pick the decisions should be based on true collaboration and not based solely on the policy. So that is why D is not the correct answer. So again, clear accountability is our correct answer for this question.
Ashley, do you want me to share my deck or are you good to go? I don't want to interfere, but
if you can share your deck, that would be better.
Can you see it?
Yes, perfect.
Okay. And then I'll just do my best to be your Vanna. Ready?
Thank you. All right, so the next question here. Private healthcare insurers often follow reimbursement practices initiated by Agency for Healthcare Research and Quality, Department of Health and Human Services, Center of Medicare and Medicaid Services, or the Department of Health. We got the poll up there for you. About half voted. All right, 80%. So we can go ahead and close that down. Looks like 93% hit C, which is the correct answer. Go ahead and go to the next slide. This will give us some of the reasons behind it. So C is your correct answer. CMS sets reimbursement for those receiving Medicare and Medicaid as CMS criteria for payment changes. Private insurance companies most of the time follow that, right? They set the cadence for everything else. So C is the correct answer. There was a couple B's there for the Department of Health and Human Services. They are responsible for protecting the health of Americans and providing essential human services, but they don't set the reimbursements for those services. Again, that is CMS that sets that. And then there was a couple DOH in there. DOH is a state agency. It does vary in its function, and it does depend on the state level as well. So that is why that is not the correct answer. And next slide for me, please. Thank you. So what do we need to know about the knowledge of the healthcare environment? We need to know about the care delivery models and the environmental design, particularly for those of us that have been in this leadership. When we're looking through your years of leadership, most of you, the majority, I think, were in here during COVID, right? Which was a fun time to be a leader, right? But all the differences that we had in that care delivery models and that environmental design and all the changes that we've had just in the last 5 years or so and what that means. So knowing that nursing practice and the application of that. Incorporating the research and the evidence into the practice, we talked about that a little bit earlier, and then factors that impact that care delivery and that financial status. And we'll get into a little bit more of the financial, the next section when we meet next week as well. And integrating those patient quality and safeties into care, which is really what we're going to talk about most. Go ahead and go to the next one. So that patient safety and that quality. Again, patient safety and improvement sciences, integration of those best available evidence within the practice, those risk assessments, and addressing performance gaps. Next slide. Okay, so some key areas here for identifying areas for improvement. How many of you, by a show of a thumbs up, have done a process improvement on your unit at some point in time? Lots, right? Right. That's really kind of any kind of problem that you have. That's what we try to do, right? Let's process improve. Let's look at this process and let's figure out why. So some key performance indicators here that we have. I live for process improvements. I love that, right? There's always something we could do better. But a couple things here were missed labels. What can we do for that? What is happening here? Why? What's the why behind this process problem here? Turnaround times, your discharge times, the relevant charting requirements. We're missing something that we got cited on for regulatory, right? So let's look at the process there and how do we improve that? Patient experience. We're always looking for patient experience and how you can improve. You can't get 100% of patient experience, right? You can only be at the 99th percentile for a reason, because you can always improve on the patient experience. Measures for that external customer satisfaction, and then reportable events and RCAs as well. Are just some examples. So some methodologies and models, and we'll get a little bit more into details here, but there's total quality management, there's lean, there's quality improvement, continuous quality improvement, the good old PDCA, and then Six Sigma, just to mention a couple. But what you really see for those they are organizational wide, looking big picture kind of thought process, right? It's looking at a problem, but what's the why? What's creating that? What's all these other things that are happening around the environment that come to that too? So total quality management is one of them. There's a management commitment. There's broad-based employee empowerment behind here. We talked a lot about those unit-based councils and how that staff is empowered to make some changes here. This fact-based decision-making, make sure that you have the right facts, right? I always like to say, take the drama out of it, right? But take the noise and stuff out of it and the emotion. And what are the facts? What do you know? And what is that affecting the situation? And then that continuous improvement, always reevaluating, continuing to look at it. How are the metrics now? Do we need to continue to improve? And that customer focus. Has anyone used this model before? Andrea, you don't count. Anybody have an example of where they use this model? Do you use this frequently?
I think the example I like to share, Ashley, here is that I was part of we had trauma as a level 1 trauma center is where I worked before. And we used that to review all of our trauma cases, which I thought was super cool because it was an interdisciplinary team that came across the hospitals to get together to say, how can we improve our trauma program to help patients? And it wasn't siloed by role, which I thought was super cool.
Right, not being siloed is extremely important, right? That bigger picture thinking of all the things that affect whatever it is that you're monitoring, whether that be trauma or something else that you're monitoring, all those factors that hinge into that particular thing. So great example. Next slide. All right, one of my favorite things here is the lean process. So anybody have experience with the lean process? Couple thumbs up. So essentially you can read here on the slides, but what this is, but it's really looking at value and value stream and doing some process maps. So understanding, again, that big picture, what adds value across the organization rather than just a department singularly looking in a silo, bringing that bigger picture there and that flow. And when you really map out a flow, being able to see where's the waste coming from here, right? Like, so sitting down and really thinking about a process and going all the way from A to Z, this is the process that happens all along the way, and then taking a look at that from that bigger picture view to go, what can we eliminate out of here? What doesn't really need to happen, and for this process to happen at the end, and creating some of those efficiencies. So integrating that together, working that pool, and then seeking that to be perfection, right? So lean is also about, one, efficiencies, but also making it the best processes that it could be. So you get very, very good at it by doing the same process over and over and over again. And again, always seeking to review and evaluate. I have a little bit of OCD in my head too, so I always look at lean like it likes to, like, you know, clean out things basically, right? So if you're going to structure things and, you know, organize things a little bit, lean's a great way to be able to do that. And the next example, continuous quality improvement. Anybody use this structure before? Couple thumbs up. Oh, there's a couple more. I just wasn't waiting long enough. There you go. Quite a few people use this one, right? So structured planning approach, evaluate that current practice, incremental improvement over that, asking the questions, how are we doing? What can we do better? And what can we do more effectively along the way? So defining those success metrics, brainstorming those changes and those strategies, and then collecting that data to be able to use that for decision making. Is it doing what we thought it was going to do? Is it meeting our hypothesis, or do we need to adjust something else because what we thought was going to happen isn't showing up in that data? How do we continuously improve and test and refine that a little bit? Next one is the PDCA. How about this one? Anybody got experience with this one? Plan, do, check, act. Lots of thumbs up here, right? Yeah, this one's used quite frequently, right? So anybody have any example that they want to share for how they use PDCA? Stephanie, you smiled and I can see like 5 people and you're about it. So you have an example of how you use this?
I do. Back in 2024, I got hired at University of Washington along with an oncology CNS, and we basically opened this entire unit together. And we're currently working on getting an article published in CJON that's literally PDCA. So literally just recounting everything that we worked on, all the education, all of the hiring, all of the planning, all of the everything into words, as much as we can into words. So that's basically yeah, just a recount of all the work that's already been done.
Great. Congratulations on your article. That's awesome.
Thank you.
And again, used for many various different things, right? We're taught this one quite frequently in nursing, so we tend to, in nursing leadership, use this one quite frequently as well. And the next one is Six Sigma. Again, minimizing that variation, reducing that error rates, and focusing on eliminating those deficits, right? So some examples that are on the screen here for you are long wait times in the ED. Again, going through that process, define the problem, what are we going to measure, how are we going to analyze it, what's the improvement process that we're looking for, what's the control process here, and then continue. You see that's in a circle, right? It's in a circle for a reason. So you're constantly reevaluating, process defining, is it working, is it not, do we need to continue, do we need to tweak something for, again, those processes that are out there. So process around registration is another example that's listed on there, right? So lots of different things for organizing and looking through throughput and all of that kind of stuff that affects our patients too. Biggest thing for this is that it minimizes that variation, right? So creating that consistency in process. And next we're going to start going through a little bit of tools. And here is going to be really the dynamic piece where I'd love some engagement. We had a lot of years of different leadership here. So as you kind of look through some of these, if you can think of examples of how you use some of these charts when we get to them, that would be very helpful to be able to share that. And you'll notice that there's a lot of different charts and things here because we don't, as nurses, we don't use just one, right? There's not just one kind of dashboard that you have. as you're going through. There's different things depending upon the situation and what data you're looking and trying to pull out and apart from what kind of graph or chart that you would be looking at. So let's get into some of the examples. Here we have the good old run chart. How many of you have used a run chart? Couple thumbs up, lots of things we've used run charts for, right? Run charts are used for patterns which emerge over the time. You can see here, this one has, from the beginning of September until the end of September. It's looking day by day by day for that urine cultures is what that one is, what they had, right? So when you're looking day by day, that's very helpful for that run chart one time period over a period of time. Anybody have examples of where they've used a run chart?
We used ours
there you go.
Oh, sorry. We used ours when we were doing blood culture contamination work, and like, where were we at? Where have we been? And like to see that going down, obviously.
Yeah, absolutely, right? Where it kind of shows that baseline and it shows you where you've been at. Yep, awesome. And you want to see it to be able to track it. Christy?
I've used run charts in the past when I was gathering data on weekly percent of all the patients discharged home within 2 hours. So I would have a baseline and then a year to date and my weekly dates. And if, I would just show the team any improvements from the previous week. And then we would go into the next chart. Why?
Yeah, and it really helps them, right, to be able to see those changes when you're trying to work on a process, right? Like we put this interaction in place here, and maybe we have a ticket here for this part in the run chart of when we did this intervention. And then, a couple weeks later, we did this intervention. And then they're able to see how their interventions are affecting the data as well.
Mm-hmm. Or even if something's going on in the hospital, right? So maybe we have patients who we're waiting on guardianship or something like that. That impacts that metric, and it's good for them to know that and talk about it.
Yeah, we got a lot of great stuff coming up in the comments here too. Falls, call light tracking, bathing compliance, HAT goals, another couple falls that are on there as well. So restrained sitter utilization, first case on start times as well. Lots of different things that you can use those run charts for. Let's go ahead and go to the next example, which is the Palel chart. Anybody use this? Couple people shaking their heads that I can see. Couple people up there. So factors which have the greatest cumulative effect on the system and the process, focus most impactful and influential factors. So you're able to see, you can see here as an example, there's measurements, materials, personal, and these are just kind of made up some charts here, but which one had the most effect, so that cause and effect kind of reaction. Any examples that people have used this for? You can put it in the chat if you'd like, or go ahead and just speak out.
I work in radiology, and we use this chart a lot whenever we're showing like the different modality volumes, and for what imaging that we are doing the most of. So like whenever we were trying to evaluate our, whenever we call a stroke code, calling a stroke code activates a CT head. And so we were trying to see how many CT heads we were doing and how much volume that is compared to the rest of our CTs.
Yeah, that's an awesome example. And I see, reasons for discharge afternoon, changes put in place with hand hygiene for compliance. And again, that patient falls, right? So we mentioned patient falls in the last one, and we mentioned patient falls in this. So there's multiple different ways and charts to be able to show the data, again, depending upon what way or how you're trying to tell the story to the staff to understand. And the next one is a flow chart. Who's used a flow chart in the past? Lots of people here. Yep. This gives me, flashbacks to my chest pain accreditation time when I was, right? How do you process map and flow things? And each one of these, for those of you that aren't familiar with these charts, each one of these shapes means something different on of it too, whether it's a decision making or things that are coming out of it. Patient care algorithms is a good process there, right? Just recently used this too for virtual sitters, and what is the decision making that the frontline makes for when they can use a virtual sitter and when they should have it in person, and what does that look like and who they call. So again, those flow charts of all of those processes, the cath lab, SNEMI response to different algorithms upon the patient. Great example there as well. And you focus on the problems occur when you're mapping this out, right? That's what you're doing. You're looking at the process from A to Z. What's working, what's not. Oh, wait, I can see here this process isn't being followed right here in this section, so we need to adjust this a little bit and plan a little bit differently. And then it is providing that consistency of everyone doing the same thing in the process. And the next example, cause and effect diagram. Fishbone. Anybody use this one? Couple people? Ellie, I see your thumbs up and you're on my screen. So any example that you could give us?
The biggest one and most recent that I used this for was when we were going through on our falls team and like, what are the causes for this and how can we narrow it down to, what's the biggest cause and how we can fix that. So we fishboned a lot.
Yep. And sometimes they can kind of get a little out of control, right? When you really start getting into the weeds, you'll have these big, huge fishgrams, right? But they are beneficial to be able to, again, pause, look at the big picture, think through what's hitting this, what is that cause and effect, and what can we process improve here. A lot of times it says here, used in RCAs as that example as well, too. We had a problem of something that occurred. Why did that happen? And what are the things that led to that, that lead to that cause and effect as well. And analyzing our unusual occurrence reports. Yep. Histogram. Visually display that process parameters using different frequencies and variations. There's also a bell curve that goes with a histogram. Anybody use this one? Couple people? What are some examples of when we've used histograms? Looking at the time of day for falls. Yeah, that's an excellent example. Timing of discharge. Timing of admissions, referrals to clinics, staffing acuity variances. Yep, great examples. And the next one is a scatter diagram. Anybody have any experience with a scatter diagram? Any people that really, really like quality here in this group? So the scatter really kind of identify a couple people there, yeah. Some people not so much, right? Just wait till we get to finance and I ask you that same question. So, identify relationships between two variables, test effects and changes on one another. Any examples in the chat here for how we use scatter diagrams? Clint survey results. Yep. Where you can see, like by employee or even age of employee, right? And where they are kind of there, a little bit for Flint surveys. Temperature monitoring for vaccines. Yep, that's a good example as well. Yep, great. And the next one is a control chart. Here's my quality friends. They usually like this control chart for quality, right? So it compares the results with target as well as the upper and that lower limit. When you're looking for benchmarking and you're looking at, where your targets are, what's the higher benchmark, what's the lower benchmark, what are we trying to get, tracks that quality indicators, again, with the benchmarks and the targets and the thresholds there. Sometimes used for patient experience as well, to kind of go, again, those benchmarking. If you're working to be in that top quartile, where are you at for that? And what do you do a month by month? And what does that look like? And then the good old Cotties and Clapsies and those kind of things too. Anybody else using this for different ways? Staff retention numbers, hand hygiene. Yeah. Yeah, good examples. All right, the next one is dashboards. So what are dashboards, right? Dashboards are just a report card comparing several different indicators, various things for dashboards, right? My organization uses Power BI. There's things that are Epic dashboards. There's all sorts of dashboards that you can create for your organization as well, but viewed at a specific point in time. Vizient has dashboards, right? Everyone has a dashboard. Give me a dashboard for everything, right? Yes, exactly. Because how do you know what you're doing when you can't see the data to be able to track it, right? And there's lots and lots of different data out there, and you have to really put that into a digestible format to be able to tell your story, not only to your team, but also to see what's working and what's not working, right? And so dashboards really provide that opportunity for us. And they allow you for corrections in that timely manner too, so that you can see real-time stuff with dashboards. I'm a big proponent of dashboards too. And then the scorecards. This is another great example here. Anybody have an example of how they use a scorecard? I'm sure we've all used a scorecard at some point in time. Hospital-acquired conditions, tracking quality measures. Yeah. Donor experience, donor network notifications, patient experience, med scanning, productivity, quality, care. I've been in my position here as the chief nurse executive for 2 months, and really what we decided was we are a relatively new organization, a new system coming together, and so our slogan is One AHN Nursing, and we came up with a scorecard that really compares every hospital by hospital with certain metrics that we put based upon our strategic plan. But what it did was able to see us against our other, colleagues to say who's doing really well and who's struggling and how can I reach out and what does this look like and how do we share some of those best practices. So that's one way that we use scorecards here, and it aligns to where we're at with our progress for our strategic plan. All right. Any questions on that section? I know we kind of went through that a little quickly. Some sort of, and Andrea, correct me here, know your different charts and those kind of things, because there will probably be a question or two based upon how you would leverage data in that. So when you get these slides to you, to please review them and kind of think through, when you see one of those slides, if you can have an example in your head of how you use it, that'll probably help you a little bit for any of those questions that may come up too.
If you think about it from an application perspective, it's really about how would you use the data? What's the best way to explain something to the team, and just knowing where the best sources of information to help drive decision making for process improvement practices and things like that nature, if that's helpful.
All right, patient safety. So implementing our best practices, our incident reporting, ensuring that medication safety, staffing, we've talked about quite a bit of examples of staffing there, supporting research, developing those policies and procedures, and then that focus model on underlying cause and events. So a couple examples here that we're gonna go through and go to the next slide. This is one of my favorite quality slides. I used to give an orientation piece to our new team members, and I always use the Swiss cheese as a good example when we're talking about zero harm, right? Because when you start looking at, your RCAs and environments and things, and what happens, you had all these different circumstances that all added up here, where just by happenstance, all these things fell through the cracks, which led to your event at the end of the day. We're all human. We all make mistakes. And so looking through that whole picture to, again, kind of process, improve a little and see where are those things happening. And what processes can we put in place from a human standpoint that you're going to expect error? And then things that you can put in place that are kind of hardwired and prevent some of that as well. Next slide. So economics and policy, really aligning our department and organizational strategies with current developments in healthcare economics, policy, and legislation. How many of you have department policies? Most of you, right? Yep. We probably all have at least one department policy, right? Why was that? Think of a department policy. Why was that policy created? Anybody have an example why a policy was created?
We recently kind of did a policy on when like a new tech is allowed to float, basically, because people were just getting floated willy-nilly, like, oh, hey, you're new, it's your turn. Like, so we created a policy that each unit can follow on, like, when would it be appropriate? Because if you're 2 days off orientation and that was 3 weeks long, you probably shouldn't be floating, to another unit because you're really not secure in your role yet. And it was actually leading to increased people, leaving. So they weren't happy. And that came out in those exit interviews. And so that was that process improvement that we did with it.
That's a great example of using that feedback from staff, right? And you created consistency, right? You created consistency between leaders in different departments so that they were doing it the same way. That's a great example. Jennifer, I see your hand up. Go ahead.
I remember when I was in ICU, the unit-based council, we decided to do a standardized practice change where when when the patient passed away, we created a format of how to document all details about the death, and making sure that we follow a certain checklist. So what we did is we standardized the practice by creating a shortcut name, a short note, where every nurse uses the same code, and that means same sheet, and documented in Health Connect. And after that standardization was created in ICU, it got implemented in other units as well. So now every time I see a patient pass away and I look at that form, it brought back some memories. So
yeah, how it got started, huh? But it's evolved as well.
Yes,
right?
it did.
So you don't just create a policy and kind of let it be for the next 20 years, right? We constantly evaluate that policy, and they expire for a reason. They have a renewal process for a reason, so that we can look through them to go, are they still applicable for our organization? Has our care model changed? Has something else, legislation come down that has changed this model that we need to look, right? They're constantly being reevaluated. Has the evidence changed? Is there a different way of practicing now that we need to be entering into those policies instead? And I also, as probably just a personal belief here, but I think we can over policy a lot too, right? So, Joint Commission comes in and they say something, and we put a policy together, right, to fix, get out of whatever it is. And so really being able to evaluate, does it make sense for this to be a policy, and why are we creating it to begin with? Or when you're reevaluating some of these policies, do we still need this policy, and can we, lessen these policies a little bit too? And my personal favorite is when some of the policies are like 6 pages, 10 pages long, right? Our frontline staff's not reading those, right? So how can you pare it down where it really is
direct to the point?
What needs to be in a policy, right? Because you can over put things into a policy as well, and then hurt yourself in the end because you don't follow it exactly. So being cautious of all of that as we are creating and reviewing and looking at policies for our organizations too.
Thank you.
And next slide is that regulation. So knowledge of regulatory and accreditation standards and rules. How many people are, Jennifer, you had your hand up, go ahead.
Oh, no, it's okay.
Okay.
Try to remove it.
How many people use Joint Commission? Any? Lots of thumbs up. Anybody use DNV? Couple thumbs up for DNV, different accreditation standards. Similar. They all go to CMS at the end of the day, right? But different accreditation standards there that how they do it is a little bit different. Doesn't make one right or wrong. It's just a little bit different. But they, hold us to that knowledge of that regulatory and that accreditation standards and those rules to make sure at the end of the day that we're doing safe things for not only our patients and families, but also for our staff, right? And some of those rules and regulations and achieving and maintaining that compliance. You have to show that you are, you have the data to be able to support that we're in compliance for these certain regulatory things as well. And then, of course, the responding to the deficiencies, right? Because we are all human and we are all imperfect, and usually they're going to find at least one thing that we could do better, because that's part of process improvement, right? There's always something that we could be doing a little bit differently and a little bit better. And sometimes those regulatories are there to help us see that in a different light than what we saw, or a different interpretation as well. And yeah, that's what we pay them to do, right? It's exactly, is to come and to show us, here's your blind spots that you weren't looking for, or maybe you quite missed, or this was an update that you're not quite hitting yet. So how can we help you get there a little bit too? And the next slide is the evidence-based practice. So one of my favorite as a nurse, right? Identify those strengths and barriers to implement evidence-based practice. We talk a lot about this, particularly on the frontline staff. We're always, those magnet organizations, the professional councils, we're always encouraging evidence-based practice. But living evidence-based practice on the frontline staff it can be a little bit challenging. And getting them to think that culture of always kind of, it's not just because this is the way we've always done it. There is evidence behind there to support it. Or as a nurse, we can create the evidence, right? If we really have a hypothesis that there's a better way of doing it, how do we track some of that data and put in place and do some of that research behind it to change the evidence at the end of the day? So integrating that evidence-based research into practice. Does anybody have any good examples? I love that we have a variety of nurses here. We got over 40 nurse leaders that are kind of in this all the time. Anybody have any best practices that we can share with each other on how you really get your teams to think about evidence-based practice? Somebody's got to get, there you go, Lori. I see you coming off.
I got something. And I'll just tell you, we were having a difficult time with falls a couple years ago, so I joined a bunch of different seminars and trying to get ideas on ways that other facilities handle falls and how to identify. So we kind of took a bunch of information. Fortunately, I work for a facility who has a very robust quality department, and we partner really well together to come up with, I don't know, out of the box thinking of ways to help us with situations. And this one, we started to trend 3 years back information regarding patients who have fallen at our facility. So specifically if they were male, female, age groups, time of day that they fell, where they fell, was it alone or witnessed, were they on new medications, what medications were those? And so we kind of really tracked all these new things regarding our patients and put together what a fall patient looks like at our facility. So then we took all that information, and there was some fun information, like the majority of our falls happened on a Tuesday. The majority of our falls happened at shift change. So we could really start to see some of this information. It was all evidenced on our facility's patients. So then we use Epic for our EHR. And so we took all those variables and created a report that would pull for our patients that day who met all the criteria of our patients, and we deemed them as our high fall risk patients. We changed their color of their gown. We changed the education that we gave them, specifically why they're a high fall risk patient. really got the staff involved in creating this change in the education piece, and we reduced our falls. I believe we're at 5.4 per thousand patient days, and we were down to 1.2.
Wow.
Yeah.
Amazing job.
So that's a
Yeah.
fun one.
Now it's gonna be my follow-up question. Did you publish it?
Working on it.
Yeah, there you go.
Yeah.
Right, because we do a great job of thinking through that, but we don't necessarily always think like we need to put this out for others who are struggling, because we're all struggling with
Right.
the same things, right? Like,
Right. And it's just the
let's
time,
share.
it's just the
Yeah,
time that we
it's
have to do
time.
it. So anyway, yeah.
Yeah,
That's a fun one.
absolutely. Great example. Thank you for sharing. Appreciate
Sure.
that. All right, so our last couple minutes here, we do have one other scenario here, similar to what we did on the last one. We'll give you guys a couple minutes to just kind of think through this, answer the questions if you'd like, scratch them down on a piece of paper next to you, and just really kind of think through this. And then we'll give you about 5 minutes or so to kind of go through those 4 questions, and then we'll just have some group talk. It's 1:55 here on some of those answers. So question here is, you've recently assumed the manager position of a surgical unit. You've heard that the previous manager left in frustration due to the inability to demonstrate performance improvement on such key metrics as patient satisfaction. The staff on this unit have told you that they do not have time to focus on satisfaction issues. So list some of the data that you would need to consider in developing the solutions, identify the most important first step. How would you engage the staff in the PI improvement, and what mechanisms might you put in place to hardwire those processes changes to work? got one more minute here in the interest of time so that we can get through all the questions. All right, anyone want to take a stab at answering question number 1? Laura's got some good answers in the chat there. Show the data, provide the why. Does it link to the overall performance? The Press Ganey scores, know what those are, right? We're talking about patient experience here. Monitor a period over time. What is this? Identify what the staff is struggling with. Good responses there. Michelle says, identify areas of focus, which metric? Low score and survey question, which one is that? Create a unit-based council, recruit strong players, drive that change, engage that staff, explain the why, and review the scores. Good answers there. And Andrew, if you want to go to the next slide, that'll give us some of them. Consider, right? Those nurse-sensitive indicators, that patient experience, the core measures, the unit-specific outcomes, all good things. I think we mentioned turnover data, engagement scores. You guys kind of hit most of these as well. So question number 2 is identify the most important first steps that you will take to begin your improvement. Thoughts on that question? What's your next step? Some of you mentioned it as you were doing some of your chats too. What are we going to do to improve performance? Anyone want to go off mute or just talk in the chat? Set goals and outcomes. Identify the root cause, develop team-based improvement plan, get to know and engage staff, see what they as barriers, connect the why. We mentioned that again. Christy, your hand's up, go ahead.
I think going into the patient rooms and talking with the patients and understanding what they're experiencing, and then sharing that feedback with the team, whether it's positive or negative, because it's definitely making an impact on our patients' experience.
Yeah, absolutely. So here you see, things to consider, setting those expectations we mentioned, right? What are we monitoring and what are we expecting? Establishing that outcome measures, what we're looking for, and acknowledge those concerns and the barriers that are out there too, right? What are we trying to fix?
I think one thing that helps here, Ashley, is understanding the storytelling. So if you've got some really great stories to tell, good or bad, I think this helps motivate the team to understand why I want to take part in this. And sometimes it's even pulling from personal experiences of our loved ones in hospital settings or something, as this example may show.
Yeah, it's when you experience healthcare as a family member, you experience it much differently than we do every single day, right? It's those things that you look at that are a little bit different that you go, oh, this is a different perspective than what we have in the grind in the everyday. And so question number 3 is, how would you engage staff in the PI improvement? Thoughts on question 3? Meet with the staff, get feedback, resolutions to concerns. Educate staff, prioritize one topic. This is a little bit of 2 and 3 thrown together here. Establish buy-in and have staff take ownership. Identify opportunities, barriers, and identify some solutions. Yep. Connecting the patient's experience through that rounding. Yep. Ask the staff. Yep. Have them own it and develop the solution, right? Even if you kind of nudge them a little bit, right? When it's their solution, you get a little bit better, different buy-in than when it's your solution, right? So yeah, engaging them to come up with the answers. So gather feedback from the staff on those PI barriers, gather that data, look for variations in that practice, and again, gather that ideas from staff. So all great answers in the chat there that go right along with that. And then finally, what mechanisms might you put in place to hardwire process changes that actually work? What do we think here? Checklist, process maps. Validation tool, make it part of orientation. Yeah, that checklist, right? You're setting those standards, you're setting those expectations, process observation, continue to monitor the change, plot the data, share the data. Share the data, you have to run there twice, right? That's very important. Make sure you share what we're actually doing, monitor progress, and share that feedback. Celebrate the wins. Absolutely. And we can go ahead and go to the next one. Here you go. So consider that, remeasure, create those SMART goals, set those expectations out there, reevaluate that progress, and here's the celebrate the small wins as well. So wonderful. We got about 2 minutes to spare. How's everybody doing? Hanging in there with us? 2 hours today? Does this format work okay for everybody? And we had a little bit of technical difficulties with some of the sounds for people, but
Okay. Fantastic. So I think we have a couple of follow-up items. Looks like some timing for different time zones needs to be corrected. We're going to take care of that. The slide deck that we've shown here for the what we call the faculty version will be uploaded in the LMS for you. We will follow up with the LMS team about getting slides in advance of them, so you have the opportunity to document on them. That was something that came through. So we'll definitely work on those things for next time.
wonderful. Good feedback, everybody.
And you'll get practice questions with every section. There's 2 built into everything, and then we've got a few things maybe planned for the end, depending on how well how we get through the material. All right, then with that, we'll close today's session, and we will see you all next week. Thank you so much, and have a great week, everyone.
Thanks, everybody.
Josie, you don't need to do any pre-work for before next session. We'll do them together. She's not there. Okay, great.
Sorry.
No, it's okay. I just let